Good evening, everybody. Welcome to this session of 49th Comprehensive Course on Echocardiography. I request everybody to silence your mics and so that we can do the proceedings. Dr. Anil, your mic is still on. Please, my humble request. Dr. Paras sir, can you unmute yourself?
Yes.
Okay, thank you, sir. Let's move on and let's have this new session of 49th Comprehensive Course on Echocardiography. We have with us none other than Dr. Col SK Paras, who has been the past president of Indian Academy of Echocardiography and the Cardiological Society of India. He has been instrumental in creating an Echo Academy in India, and his knowledge, which is the best in basics, he is going to deal about how not to miss a lesion by conventional imaging, part 1 today, by himself, and a lot of collection of very dedicated teaching AVI clips, which helps you making this particular session very easy to understand. With these few words, let me hand over a mic to Dr. Col SK Paras to start with this proceedings.
Is my slide seen or not yet?
Not yet, sir.
Now?
They are visible now, sir. Can you enlarge them for us, sir?
Yeah.
Perfect.
Actually, the idea of this talk is because you are firstly, it is divided into two parts. Because presently you are very new to the topic, so the first part will be made very simple. And because still you will have some difficulty seeing the images, the second part will be a more detailed one in which we'll show you all sorts of common AVI videos which we see in our day-to-day life. But here we'll concentrate only on this also, and thus I'll let you know why this is important. Because if you really follow this slides also or this lecture, it will take you extra far. Now, the two most practically used points are any chamber subjected to prolonged pressure or volume overload increases in size. Just remember this. For example, there is a pulmonary hypertension. The load on right ventricle, the right ventricle increases in size. Increase the right ventricular pressure, the load is on RA, so it increases in size. So any chamber subjected to these increases in size, and remember, give full importance to 2D echo because 2D echo gives a semi-quantitative idea of severity. Though that is very important. Now, to give you this example, although you will not be able to understand some slide, but try to visualize. Suppose this is the IVC and this is the right atrium. As you know, IVC uh, drains into the right atrium, and in a normal IVC, it doesn't enlarge in size and shows a good inspiratory collapse. And why this all happens will be shown to you when you proceed further in the course. So remember, whatever we show you will be shown to you in a later part or so. Now, what will happen? If the right atrial pressure is increasing, then IVC has to work against an increased pressure. So any chamber subjected to increased pressure increases in size. Now you see this is the IVC. Now see here. Now you see. Now the IVC has increased in size and collapse diminishes, IVC becomes prominent. So that means because it is now a draining into an increased pressure chamber, so any chamber subjected to increase the pressure increases in size. Now see further. Now see again, as the IVC pressure increases further, so we calculate the RA pressure. This becomes, you see, the further increase in IVC and decreased contractility, giving a pressure of about 15 millimeters of mercury, the mean pressure. Again, you see, it's an extreme degree, you see, an extreme degree of the increase in size, the normal being about near about 2.0 centimeters, but here it would be almost about 3.5 centimeters and decreased collapse. So, and why the decreased collapse? You forget about it. The idea showing these slides is that as the pressure increases, the proximal chamber goes on increasing in size. If you might just, say the L increases in size. So we'll just discuss it. So we are going to some revision slides. These are the usual views you always take: parasternal, apical, subcostal, and suprasternal. So we'll only constrain to some of these. Now, this is what we told you during Doppler. Always have an ECG training, and this is always the sequence of events. A 2D echo, which will give you a semi-quantitative idea of any lesion, a color flow mapping to show that you are parallel to the Doppler, because as you told you that we have to be as parallel to the flow as possible to get a good velocity. So these are some of the ones which I already discussed earlier. And this I told you, say, we have seen many of you doing an echo, going on removing the transducer, going on doing this, that side. So never use a transducer, and you see, you will not miss an imaging. Look at the screen and not the transducer. Many of you who are doing from the right side want to see where you have kept your probe during apical view, and that you don't look at the screen and you miss an imaging. So don't, you look also at the screen and at the same time, and then follow these three principles: sliding of the transducer, that is up and down, angulation, slight angulation here and there, and rotation. So these three things, if you follow, you will never miss an imaging, or you will get used to it. And the respiratory maneuvers. Sometimes you get a better imaging during inspiration. Sometimes you get a better imaging during expiration. So look, you see which respiratory maneuver gives you the best imaging. And then with these things, you don't go on removing transducer at times. And this we told you that any Doppler, any blood flow which is towards the Doppler gives the Doppler above the baseline, known as the positive Doppler shift, and the one which is goes away from the transducer flow, it gives the negative Doppler shift. So that means you can see the which way the blood is going. To give you just an example, now these are an apical view, and remember my left ventricle is always on the left side. Now here, any view you take, the transducer is pointing above downwards. Here you take, again the transducer is pointing above downward. So in every view, the transducer is pointing above downward. So any blood which is going towards the transducer, like a mitral valve, will be above the baseline, and the one flow which goes away from the transducer will be negative this. So the main idea of showing this is, remember this is always now these are some of the as long as it is less than thickening, is sometimes found in elderly individuals and hypertensive. So don't get missed. And when you get this thing, the importance is that if you measure LV here, you will get a very small dimension because it is here. If you referred as mass, but these can be some the wall of the inferior vena cava. You see, this bit is sort of curling structures here, although, and you see here again, you see this is also seen from a subcostal view. So any view you take where there is an RV, you will find these stands. So these sometimes can be a normal variant, except for some obstruction, some EVA problems or so. But you see, this is the IVC and this is the RA, and you feel this is the these are the normal variants also. Oh, this is the you see this is the aortic wall, aorta, LA. You see this sort of a scratchy movement of the aortic wall during systole. This can be a normal variant. During the M mode days, almost 50 years back, when these should occur in diastole, you to say that it is a pathological thing. But here you see the aortic wall opens in systole and closes in diastole. So this sort of just the push of blood into the aorta, this can be a normal variant. If you want to write in your report, you can see the seesaw appearance of the aortic wall in systole could be a normal variant. Now, see, sometimes you see, as you go further in the court, this is a prosthetic wall, a mitral prosthetic. This is the left ventricle. Almost 90 to 100% of the prosthetic walls, you see this sort of a coarse contrast echoes in the left ventricle. When the blood comes and strikes against this prosthetic wall, it produces this coarse, this blood, this coarse crystals of this of a prosthetic wall or the contrast echo. You can see something moving, which is a larger one. So this is a normal one, but but as compared to this you see, this you see a fine smoke. This is abnormal. This is not a sort of a bigger particles. You see, this is the left ventricle, a very poorly contracting left ventricle, and hardly any movement or so, very poor ejection fraction. And you see, this is the, you see again, you see, this is the normal ones, a coarse sort of a contrast. And here you see, this is a smooth one. You will see plenty of these as you proceed further in the course. So don't remember one thing in my talk. If there's any confusion, you can go on interrupting me and go on asking things if you want something, rather than keeping it in the end or so. If you have any doubt, please interrupt and say, because it is an interactive session. In the these structures get thickened. So this is a parasternal long axis view. This is the interventricular septum. This is the inferior wall or the posterior wall. And see in systole what happens? This shows the systolic thickening. This shows the systolic thickening. And they move towards each other, and the LV cavity becomes small. So in a normal LV, during systole, the LV cavity becomes small. There is a thickening, normal systolic thickening of the various segments, and you see there is a symmetrical motion. They move towards each other. And you see, if you take this, you see, as compared to this, see this. This occurs after a cardiac surgery or anything. Now here you see they are moving opposite direction, a jerky motion moving in the opposite direction also. You see, and so again you see this is the normal one and this is the abnormal one. This is the jerky. This is the motion occurring this, and see in a normal person you see this is diastole, this is systole. By this time, you should be knowing that from the QRS complex to the T wave is systole. From the T wave to the QRS complex next is the diastole. So you see in systole, this in systole there is a thickening of the septum and the posterior wall, and this is diastole. So you see in systole there is a reduction in the LV cavity size. There is a systolic thickening, and they both move towards each other. Diastole in opposite direction, systole same time, and you see here, you see this is the one we showed you just now. Here the diastole comes here, here the diastole comes here, here the systole comes here the systole comes here. So this is known as a paradoxical septal motion because of the
सर कुछ दिख नहीं रहा है सर, सिर्फ
क्या नहीं
आप
दिख
दिख
रहा
रहे हैं
है?
सर, सिर्फ आप दिख रहे हैं, वीडियो कुछ नहीं दिख रहा है,
अच्छा,
स्क्रीन नहीं दिख रहा है सर।
अभी
नहीं सर, बिल्कुल अभी तक कुछ नहीं दिखा, सिर्फ आपका लेक्चर चल रहा है।
तो आपने बताया क्यों नहीं अभी तक?
डबल
सर
क्लिक करें।
मैसेज किया था।
हैं?
नहीं नहीं, हमको तो दिख रहा है, लेकिन आर यू ऑन मोबाइल?
ना
मोबाइल पे कुछ
नहीं, आईपैड है मेरे पास, लेकिन वो JROP आ नहीं रहा है ऑप्शन में, डबल क्लिक किधर
मैडम
करना है?
जस्ट लॉग आउट,
डबल क्लिक
मैम
करो।
प्लीज लॉग आउट एंड लॉग इन अगेन, स्क्रीन इज
अभी-
विजिबल।
अभी
Okay.
let us
Yes.
ask the other person. Can you see
Sir,
this?
सर यस सर दिख रहा है क्लियर
Yes, sir.
visible
Yes,
है।
sir. It is visible.
Visible, sir.
Yes sir.
Screen is visible. Visible, sir.
If you have
Screen
any
is visible, sir.
problem, just log out and log in again. Okay.
वेरी गुड विजिबिलिटी सर। वॉइस इज ब्रेकिंग बट
नहीं, वो तो जरा सा.
हाँ
So you can see this, and you see this is the abnormal motion, and you see this is the normal movement towards each other, and you see here they move in the opposite direction. So this is known as a paradoxical septal motion, which can be found in any cardiac surgery, bundle branch blocks or so. Now this is also a normal variant. You see this is the left ventricle, and you see there is an echogenic line coming from the septum to the lateral wall also, and this is known as a false tendon. So you see sometimes it can be confused with anything also. So this echogenic line coming in the LV is known as a false tendon and doesn't have any significance in the usual working or so.
सर what will we find in paradoxical motion in MOT sir?
Eh?
What will we find
See,
in paradoxical motion?
so you see in this systole, both the septum and the lateral and the posterior wall are moving in an opposite direction.
Yes sir.
In systole, the IVS is moving towards the posterior wall. Correct?
Yes sir.
Can you see they're moving towards each other, and
Yes.
here they're moving against? Now here you see what is happening. It is when the diastole it is here. Here the diastole is here. The diastole should have been here, correct?
Okay sir.
And the systole should have been here. So the diastole is here because it is known as, because the diastole should be the bigger one than the systole. So here you see. So the peak diastole, you see the peak diastole is here, and you see here it is going there. So this is known as abnormal septal motion.
Then sir, how will we measure the
Yes,
measure?
Sometimes it is difficult to measure, so you have to give a visual impression, because if you want to measure a systole, diastole, you have to draw a line like this. So it doesn't go much. So you can always say that because of a paradoxical septal motion, precise LV dimensions not taken, but you can give a visual impression. For example, or some persons can you measure here, this is systole, correct? And here it is diastole. So you can give a visual impression and then say that, but that is one of the limitations in their measurements. So this is the false tendon. So the aim of the present talk is try to locate multiple lesions in one patient. The difference between you and us is that when you see only one abnormality, you focus only on it and miss the other thing. We, because of our long experience, once we scan a plane, if there are multiple abnormalities, our eyes can catch multiple abnormalities. So sometimes you only focus on one. And if you go on stepwise, it will not help you. You will not miss a lesion and will take extra 5 minutes or so. So go stepwise. In a lecture, the lecture may take 45 minutes, but in your day-to-day practice, it will take only 5 minutes extra. Then, as we told you, in a turbulent flow, always use a CW Doppler because they call it high velocity flow. So now this is, you start with the parasternal long axis view. Now you go from right to left. Now, which is an ideal parasternal long axis view is that their walls are fully open. This is the mitral wall. This is the aortic wall. The walls are fully open. The septum is as horizontal as compared to the anterior wall of the aorta, and it is continuous with this, and you get a good contractility. But the thing is only the full opening of the mitral of the walls, and septum should not go like this. Otherwise, your measurement will be wrong, as horizontal as possible by manipulation of the transducer and this. So here you start from the right side. This is aorta. All of you should know that this is aorta, correct? If you start from the right side of this, you call aorta, now see. Now here you see the aortic root is dilated. You will not miss it. And there is one more thing in it which will tell you later on. So whenever you get the hugely dilated aorta, you can think of a Marfan syndrome, a aortic aneurysm or so. And it is so enlarged or so, it is almost obliterating the left atrium. Always the left atrium is behind the aorta, whichever view you take. So this is one thing you take as you see, and whenever you see an aorta, you usually measure at, this is the annulus, say this is the annulus, and this is the largest is the sinotubular junction. Then it narrows down. The narrowest portion is the sinotubular junction, and then the aorta. So in a day-to-day practice, when you have any doubt, you measure all these things also at this level, and then the northern level, and then the aorta, whichever is visible. For example, you see here. Now, this patient we had to send for an urgent surgery with a huge big dilatation of the aorta. And this I'm not showing the color flow mapping. Color flow mapping will show you in the next topic also, because they have got a very strong sort of a chance of a rupture of the aorta or a dissection of the aorta. And because we don't want anything beyond 5 centimeters or so, and here you see, when we measured here, it was 28, and the maximum was about 71, and this was about 66. So there was a huge dilated aorta. So this always calls for an urgent thing. So that is just to see for a, how do you record an aorta, at what level you measure. Then when you're seeing this, now this is an aortic section. Now, a aorta consists of an adventitia, a media, and intima. So when there is a rupture of the intima, the blood goes into the this section, the media, produces a dissection or like this. You see, here you see the aortic root is enlarged. The aortic root is enlarged, and there is a membrane. This is the membrane which you are seeing this is the membrane which is being pushed because of the blood into the intima media surface. So you can see a dissection. So this cannot be seen always, but try to look whenever aorta is dilated. Now see, the aorta is dilated. Now every time it dilates the aorta, whenever there is a dilated aorta, look for a membrane which is a false membrane and indicative of a dissection. Similarly, the same patient, you see, this is a three-chamber view, LV, aorta, LA, and you see this is the aortic wall, and here you see a membrane. So this is indicative of a aortic dissection. So the point about that, whenever you see a chamber, look for its size, look for any abnormal structure in it, and then proceed further. Otherwise, if you see only dilatation, always look for a membrane if you can find it. And if you have seen the membrane in both of them also. Now, after the aorta, you are coming gradually to the let us say the mitral aortic cusp also. This is the right. So I will not show you something else, but after the you see, whenever you see a cusp, always see for three things. How much is the mobility? Because the disease skull also reduces its mobility. The disease, the more the disease is the cusp, the lesser is the mobility because it's a diseased one. Number C, whether how much is the thickening, whether it's thickened or calcified. And number three, the closing motion or any abnormal structure on it. So just any wall, just forget about a thing. You only see three things. How much is the opening amplitude? How much is the thickening on any abnormal structure on this? So this is the right coronary cusp. This is the this is non-coronary cusp, and you see they are combined. They are closing, opening nicely, and closing here in the. Now see here, you see you see here, this is the zoomed view, and this is, you see, this is the cusp, which is showing a convexity toward the aorta. And when the cusp, rather than, see, here you see, it is opening, here it is normally closing and opening clearly, you see. Normally, there's only straight line, almost parallel, but here you see, that you see it is a dome-like structure going toward the dome means toward the distal structure, which is known as the doming of the aortic wall, indicative of an aortic stenosis. So here we can say that there is a systolic doming of the aortic wall with a mild thickness, and if you take an M mode view, you'll understand. You see it is like this. This is the aortic stenosis. So this is what you see in the aortic wall. A doming like this will give you an indication that possibly you may be dealing with a bicuspid aortic wall and an aortic stenosis or a regurgitation. So doming you'll understand better when you come to the topics of the valvular heart disease. But just to tell you that what you look into it, now see here. Here you see it is markedly thickened. So this automatically tells you that this is a calcified aortic wall with significant LVH. So this patient should be having a severe aortic stenosis because the opening is very much restricted, highly calcified wall and LVH. So in this patient, if by a Doppler study you find that it is only mild aortic stenosis, that means your calculations are wrong. So as I told you that the 2D echo gives you a semi-quantitative idea, and you see how nicely you can say. So always see for three things: what is the mobility, what is the thickness, and any abnormal structure on it. Again, you see sometimes this, now you see, it is closing nicely. This is closing, both the cusps are closing nicely here. Now here you see, one cusp is coming into the LVOT. Remember, LVOT is always formed by the anterior mitral leaflet and the interventricular septum. So this is whether you are doing M mode, 2D, 3D, this is always an LVOT. And here you see the non-coronary cusp is coming into the LV, indicating a prolapse, and this is giving rise to a aortic regurgitation. So I'm only focusing on this. Again, see here. You see they are very closing here. There is nothing coming into the LVOT. This LVOT, nothing coming in. But here you see the movement. You see always you see that this is coming, and you see there is a gap between the two cusps, and this is producing an aortic regurgitation. So this is only stepwise. I'll tell you how. Then you see here. Again, you see this is a prosthetic valve. So all aortic cuffs will not be calcific aortic stenosis. You see, this is known as the reverberation. This is the aorta, this is the LA. Whole of this image is coming back into the LA because this is a metallic wall. So whenever you see a reverberation like this, think that it is a prosthetic wall here. Again, a calcified wall will, you see a calcified wall will, oh, sorry, I just came to the last one also. Sorry, I missed my. See, here you don't see anything behind the wall in the LA, but here you see there is a this is known as the reverberation, and this comes from the obstetric wall also. So this is the a prosthetic wall. So there can be three things. Either you see the thickness, you see the mobility, you see any abnormal structure like a vegetation or so. Many of the things we'll see. Always, whenever you see this, never forget to see either a LA or this. I'll tell you what I want to show you. Yeah, whenever you see a aortic wall, always see proximal to it here. I told you this is the LVOT. LVOT is formed by the anterior mitral leaflet and the septum. Always examine this. You will be many times you will be benefited. For example, here you see this is the obstructing membrane. This is the meiotic wall, and this is the membrane hanging from the interventricular septum. And this produces what is known as the subaortic stenosis. Always. So all these will be shown to you again with a 2D and with a color flow mapping and other things also. So here you see this is the aortic wall. And you see here everything is clear in the LVOT. But here you see there is a obstructing membrane, and you can again see from a three-chamber view, LV, aorta, this aortic wall, and see this is a membrane. And this is known as the subaortic or a membrane. So always see this. Now, then comes the LA. So you have seen aorta, you have seen aortic wall, you have seen the LVOT, then come to LA. Whenever you see any chamber like this, see for its size. Always mention the size. Any abnormal structure within it. So we'll show you always see the size and the abnormal structure in it, and then you can correlate. For example, here you see the LV is clear completely, and here you see this is the parasternal long. This is a case of mitral stenosis, and you can see there's a LA with a large and there is a spontaneous contrast echo. So this spontaneous contrast echo is usually found in associated atrial fibrillation. You see atrial fibrillation flutter associated with mitral stenosis and when there is a low flow state. So in these cases, in an atrial fibrillation, this is a very low flow state because the spontaneous contrast echo. So whenever you see a spontaneous contrast echo, always look for a thrombus. In every case of a possibly LV thrombus, LA thrombus, you will see a spontaneous contrast echo. For example, here you see, again, you see multiple clots in the LA. So that is just one example we showed you. Again, you see the mitral stenosis. Now, when we come to the mitral stenosis, then we tell you why it is mitral stenosis. And you see here again you see mitral stenosis and a huge big thrombus, and there is a clot there is a spontaneous contrast echo. So again, the patient is in atrial fibrillation and a mitral stenosis and a huge LA and the presence of a thrombus, because it is layered thrombus which is connected to one of the walls, and I told you associated with a spontaneous contrast echo. So always see for the size any abnormal structure within it at your level. Now see, with a transesophageal echo, you see a marked spontaneous contrast echo, and you see a large floating left atrial thrombus coming into this. So these are some of the examples of a thrombus or so. Then, so now here you see, now here if you see in 1 minute, aorta is normal, no membrane, aortic cuffs are normal. There is a mobile structure into the left atrium. Now, this is not a thrombus. Why? The patient is in sinus rhythm. You see, the patient is in sinus rhythm. There is no mitral stenosis. There is no spontaneous contrast echo. So three things There is no atrial fibrillation, no mitral stenosis, no spontaneous contrast echo. So the commonest structure in this LA and left atrial myxoma. So you can see that is why you, although whenever you see a mass, you always think of three things: a thrombus, tumor, or a vegetation. But here I told you why it is not a thrombus also, because of these three things which then you see a homogeneous mass like this. Now, again, you see, now see, we'll take only 30 seconds. We'll say aorta normal, aortic wall normal, there is a structure into the left atrium, RV normal, septum normal, LV normal, and LA normal. So everything you see. So now you have to see this structure. I think some of you would have seen in anybody guts. Anybody can tell me? So now you see, persons in the previous batches told that it is a thrombus. No, it is not a thrombus. Again, same thing. No mitral stenosis, no spontaneous contrast echo, and it is like a sort of a metallic structure here. And when you see this come to an apical view, and it is a ASD closure device. So you see, this is the LV, RV, RA, LA, and this is a device closure which you can see in some of the views you can show. In some you can miss it, but in some of the views. So whenever you get any abnormal structure in any view, take all the views to see the same thing. Wherever you see an interatrial septum, you'll see this, whether it's short axis view, subcostal view, or distal. So remember these things also. Now see again. So again now, so we have seen this. So now as a normal anatomy, this is the mitral wall which is attached and which is continuous with the posterior aortic root, and this is the interventricular septum which is continuous with this. So after you have finished this, you are seeing the wall also, and you see, you can forget this is a sort of a systolic anterior known as SAM, or a systolic anterior motion, but you will not understand in a 5-chamber in the parasternal long axis view. And you see here the same thing going there. Now see, now trying to see, as I told you, this is a normal mitral wall, correct? So this is diastole. It comes from the beyond the T wave, and as you know, the mitral wall opens in diastole and closes in systole. It opens in diastole and closes in systole. So you see this, and so it is single line. Now, so this is systole. By this time, you should know mitral closes. This is systole. This is anterior, and the motion is if there is any anterior motion. So systolic means during systole, anterior is this, posterior is this, and any motion, abnormal motion is systole. You see this now. Same thing. This is systole. There is an anterior motion of this motion. Now see here. Again you see. See, in systole, there is no motion anteriorly, single straight line. And here you see, during systole, there is the motion anteriorly, and during systole, so this is known as the SAM. Again, you see, this is a better SAM. This is a mitral wall, opening in diastole, closing in systole. Normally, it closes in a single line, but here you see, this is a systolic anterior motion, which is hitting the interventricular septum. So this will be shown to you when we study this. Just form an idea that how do you proceed also. Again, you see, this is the, of course, this is the doming of the mitral wall will show you. So all this will be shown to you. Nothing else abnormal motions of the mitral wall will be shown to you. So now you see, as I told you, so you have seen the aorta, you have seen the aortic wall, you have seen the mitral wall, you have seen the left atrium, LVOT. So now you see, as I told you, the interventricular septum is continuous with the anterior wall of the aorta. you see here, and mitral with the posterior wall of the aorta. So there is a straight line, but here what do you see? The aorta is here and the septum is here. So that means there is a lack of continuity. You see, normally the septum should come with the anterior wall of the aorta, but here you see. So this is a classical fellows of tetralogy. So there is a large aorta, and you see there is a overriding of the aorta. And you see this is septum, and this is overriding of the aorta. So this we call as an overriding of the aorta. Compare this. Now see this carefully and see this. Now this is an ordinary VSD. Here you see, but there is no overriding of the aorta. So this is a VSD we can see, but aorta is normal. But here you see there is a overriding of the aorta and there is a VSD. So just see this. So after you have finished this, you come to the right ventricle. Any doubt you go and ask it. So we have finished, we have gone stepwise. And we'll tell you just now how quickly you can see. Now see the right ventricle. Now see. Here you see if you see here, you can say aorta normal, no mass in it, aortic wall normal, LA normal, mitral wall normal, RVs and large. So now you have to see why the RVs and large. So this is RV, this is septum, this is LV, this is the posterior wall. So this is RV. And then when you have got, this gives you a hint as to see what is the cause of this RV. And you see there are some of the common causes of right ventricle. As I told you, any pressure or any volume or load will increase the size. So like a pulmonary artery hypertension, RVOT obstruction, ASDs, tricuspid of aneurysm, and alveoli. So these can all go. So this is giving you hint. Let's see for these abnormalities also, which are more common ones. And again, these are less common ones, but should be looked after also. So now after RV comes the interventricular septum. Again, when you see any septum, see for its normal motion in systole, its normal thickening in systole, or whether it is hypertrophied or not. So in septum, you can only see the movements, whether it's abnormal movement, whether it is thickened or not, or whether it is trophic, or whether there is a fibrosis. And you see here, you see, now this is the septum. You see here now. So if you see here, the aorta normal, aortic wall normal, LA enlarged, aortomitral continuity normal, and here you see RD normal. It has not taken you more than 1 or 2 minutes or so, or even few seconds to see this. This is those, and they always see this thickening, okay, very poor motion and a poor systolic thickening as compared to this. See, this here you see there is RE, it's a massive thickening of the septum and the posterior wall, a classical case of hypertrophic cardiomyopathy. So any thickening which is more than 15 millimeters in any segment is a criteria for a hypertrophic cardiomyopathy. So you see this, and so that is the advantage of doing a stepwise. And this is known as a asymmetrical septal hypertrophy. It is thickened more as compared to the posterior wall. So this is just a few examples of again you see this a cardiomyopathy. And these are some of the common causes. A large body surface area, sigmoid septum, we told you, athletes, hypertension, aortic stenosis. In your day-to-day practice, you'll see the most common ones will be hypertension, aortic stenosis, hypertrophic cardiomyopathy, and some other causes will also be there. Now, so what is left now? You have finished everything coming to the LV and the posterior wall, and this is the pericardium. It's the most thickest structure or most echogenic structure in the posterior wall is always the pericardium. Now you see the LV. So that is why after IVC you can see the LV. So never forget LV again. You see the size, you see the contractility, you see any abnormal structure like a mass or anything. Now, the many of these cases come like they diagnosed as a case of pericardial effusion. Now here you see, if I have to go stepwise, aorta normal, no membrane, aortic wall normal, LA normal, RV not enlarged, septum normal, and here you see, this is no the normal pericardium consists of some fluid, normal pericardium. So, and that produces a eco-free space. The signs of a pericardial effusion is an eco-free space, and you see which occurs only in systole also and not in diastole. See here, the same thing we have done in M mode. The echo-free space is only in systole, not in diastole. So this is a physiological thing or not a pathological effusion. You see this. This is the two layers of the pericardium, and you see the space only in systole and not in diastole. The first sign of a pericardial effusion is a diastolic space. So you see here. Here you see here you see it was only in systole, not in diastole. Now here you see the echo-free space is both in systole and diastole. So this is diagnostic of a pericardial effusion. So remember that physiological effusion has many of the radiologists, when they do the ultrasound, they find the same thing and they say there's a pericardial effusion present. But this is the physiological one, and the pathological one is only in diastole. And this is, of course, a large pericardial effusion. You see a huge big pericardial effusion. And you see this is the descending aorta. Any fluid above it is the pericardial effusion. You see, I'll show you one case. You see huge big space. This is the space between the two pericardial rears. And you see this patient. This was referred to us to urgent pericardiocentesis. But you see here, this is the aorta, and this is posterior to it. So this is a pleural effusion. So here you see a pericardial effusion is here. This yeah, this is the aorta. It is anterior to this is pericardial effusion, and posterior to it is the pleural effusion going behind the left atrium. So this is you see, this is the descending aorta, and this is the fluid behind it is pleural effusion. So this is the same thing shown in a different way. So now a quick examples. Now see how much time is taken. The parastern has long axis view. Aorta is normal. Aortic valve is normal. There is no thickness, no problem. There is the LA is normal. There is a normal mitral aortic structural continuity. But here you see the closure of the aortic wall, mitral wall, is behind the anterior into the LA. You see normally it is like this. When it is moving, it is just closing like this. Nothing in the LA. But here it is LA. So it has not taken few seconds, but we have know that this is a mitral wall prolapse. When you see this is the image, stored image. You see aorta normal, aortic wall normal, LA normal, RD normal, septum normal, and see this is going posterior. So you can sometimes see anywhere. And the same patient in apical view, you can see. And any wall of the mitral wall, which is continuous with the wall of the aorta, is always the anterior leaflet, and then you see again the mitral wall collapse. Again, another example, you see that I showed you. But here, when you go into detail, aorta normal, there is a prosthetic wall, LA is enlarged, RV normal, with a markedly decreased contractility of the LV walls, and there is a significant LV enlargement and a poor LV systolic function. Now you have not missed anything out of it. Now, what is wrong in this image, you cannot tell you now. What you see. Just to say, there is a significant LVH, both posterior, and if you only concentrate on LVH, you'll miss the pericardial effusion. It's anterior to this. So besides many things which you can say, and I don't want to comment here, you just did the wrong in the imaging is that in a parasternal long axis view, you should not see the apex of the ventricle. Sometimes you are forced to this, but apex is not seen. So here it is taken just 1 minute to find out. Now the same thing.
RV collapsing, sir.
Now see, this slide I told you earlier. Now, first time, now when you see this, the aorta is enlarged, LA is small, aortic valve is normal, RV is enlarged. So now this gives you a hint that why should the RV be enlarged? So now you have to, beside this aorta, you have to see for any cause which is producing RV enlargement. So this is the advantage of going stepwise, that why should RV be enlarged in a simple cases of aortic enlargement. So this gives you a hint, and by going by stepwise, you will not miss it. So now we come to the short axis view. Just take at various levels. I'm not going to spend time. When you take a short axis view, take an aortic level, take a mitral valve level, take a take at the papillary muscle level. And when you see this again, you start from the right ventricle, right atrium, tricuspid wall, right ventricle, pulmonary wall, pulmonary artery, stepwise. Again, RA you have seen. Any chamber you see, whether it is what is the size of this, any abnormal structure into this thing. And to, for example, here you see this patient was referred as the case of tachycardia. And you see here, RA, there are multiple clots. And there's multiple clots. And this is not that you can always say it cannot be a vegetation. You have to take the clinical picture. And the RV is enlarged because this led to a pulmonary embolism. So similarly, again see a tricuspid valve for any abnormality, which will show you in the second part of this lecture. Again, this was again difficult for you to see an temperature. And then this because you are only discussing a thrombus, you see a thrombus. When you go this, when you are seeing a thrombus everywhere, you see a thrombus in the bifurcation of the pulmonary artery going into the right pulmonary artery. But this is much beyond you. So once you are going this, go from RA, see the tricuspid wall, go for RV, go for pulmonary artery, and always take a seat for this. Always take a seat. This is the right coronary cusp. This is the left coronary cusp. This is the non-coronary cusp. A non-coronary cusp is always toward the interatrial septum. It's always toward the interatrial septum. And here you see here, in diastole, it looks as if there are three cusps. 1, 2, 3. See, 1, 2, 3. But in systole, you see, there are only two cusps and elliptical shaped two cusps. So that is the advantage of not taking in diastole, but only taking in. Now see, this is an aortic cusp closed in diastole. It appears there are three cusps, but here you see. And this, of course, sometimes you can see. Again, you told you this. This will show you later on. So now we have come to apical
Sir,
views again.
bicuspid aortic valve, please repeat, sir. Bicuspid aortic valve, please repeat, sir.
See, there's only two elliptical cusps. One this side, one that side. One this side, that is only in systole you can see. One this side, one that side. Don't worry, you can see. You can somebody can say that it is unicuspid also, but there are differences also. So you can see, like if you are taking this, keep your hand like this, so you can see this. That is the bicuspid wall. And sometimes you can see the cord. This is the right coronary cusp. This is the left coronary cusp, and any cusp toward the interatrial septum is the non-coronary, and this is the accessory cusp or the track 4-1. You can see sometimes you get it. So now you see Again, we have shown you this thing. When you come to the fourth chamber view now, again LA, RA will go in one go. So that you LA again see for any size. Number two, see for any abnormal structure into LA. Same thing you see for RA, any abnormal size. See for interatrial septum, and whatever that is, whether it's stable or not. Then always see the presence of two AV walls. Now you see this is the mitral, this is the tricuspid. The tricuspid wall is always attached toward the apical side. Even if I keep RV or LV this side, you see the tricuspid wall. Mitral cusp is attached here. Tricuspid attached more apically. So the cusp which is more attached apically is the tricuspid wall, which is always related to the right ventricle. So this thing we see here. Now you see again I showed you the same thing in a parasternal long axis view, that again a left atrial myxoma which attached to the interatrial septum. Now this is sometimes you get confused. This is the LV, RV, RA, and you see this is a pacing electrode seen into any echogenic structure. I told you any abnormal structure you see. So if you're in abnormal structure, if you can't recognize it, always say that there is an abnormal structure, but the only structure which is coming from SVC, IVC is the pacing wall. And here you see this is a mitral stenosis with ASD. This is left right shunt. Any idea what it is? Lutembacher. Lutembacher is any type of mitral stenosis, any type of ASD, either congenital or after a balloon dilatation. And any septal defect which is more toward the valvular side is the sinus venosus. Forget about it. Now always see the walls. Again, you can see this is the tricuspid wall, this is the mitral wall. And whenever you see this, again you see, this is the reverberation, which you see into the LA. This is the prosthetic mitral wall. You can see the reverberation. And when you see the flow across it, and when you don't see a reverberation, sometimes it can be a tissue wall. But we'll let you know when the lecture on the tissue wall comes. Now, I told you always look for the type for the whether balls are present or not, and whether it interventions or not. See this. You see the audience plane. You take LV on the left side. What do you see? So you see the LA because the pulmonary veins are attached to it. LV single wall. There is no wall here. The tricuspid wall combines between the RA and the RV. So there is no valve into it, hence this is known as the tricuspid atresia. Atresia means absent, or hypoplasia means reduced in size. So this is atresia, and you see there is no tricuspid valve in it. So you always see whether all the two valves are present or not. Now see, if you don't see these valves also, that they are opening one. Now here you see that one is opening, one is not there. And why the RV is small, we'll tell you later on. Same thing, our view. Again, you see the sinus venosus or anything. One single wall and other one there. And इसको भी आपको congenital heart disease में बताया जाएगा. This is Eastern's anomaly. Marked displacement of the septal leaflet. These cases will be shown to you again when we take a congenital heart disease, but just to show you that always see whether the state of the two balls. This is the mitral ball, and here there is a markedly displaced septal leaflet. Now come to then we have seen this, just see the LV for any myocardial injury, presence of interventricular septum, because sometimes you can get a case like this. and there are two cusps, mitral and tricuspid cusp, kissing each other in diastole with no interventricular septum. So this is known as the univentricular heart. And you see the blood is going from both the sides and mixing into this. This is something, this is when you see, when we tell you the ischemic heart disease, then we'll tell you the signs of a myocardial infarction. But remember, we always see a systolic thickening and a wall motion abnormality. So depending upon the segment involved, we can see it. Again, you see different, another wall, you can see there's hardly any systolic thickening. A normal ventricle increase the thickening systole, but here you see there's hardly any systolic thickening. Again, INT. We'll again show you later on this LV aneurysms. Now, then you always see for a subcostal, you now see, always you wonder what is happening here. I'm just trying to show you that the image goes in between. If we ask the patient to not to ask him to hold the breath, you see this thing. When he's taking inspiration normal, you can see four the chambers. So here that is why when we take a subcostal view, we always tell the patient to hold the breath in inspiration so you can see all the four chambers, right ventricle, left ventricle, mitral wall, and you see again here also the tricuspid valve is more attached to the apical side. So this is the how you take it. It is that always take a deep inspiration. And here you can also see these pacing electrodes, which are seen as an echo because they go from this the SVC to this. And sometimes you can see such cases in with a pacing electrode by mistake has gone to the left ventricle. Instead of the right ventricle, it has gone to the left ventricle. The explanation will be given to you. And lastly, you come to the suprasternal view. There are many things you do in a always practice it. In when you learn about aortic stenosis, aortic regurgitation, the value of this is ascending aorta, arch of the aorta, and a descending aorta. So always practice all the views or so. And here you see here the normal flow. Here you see there is a turbulence, narrowing. There is a narrowing here. So that narrowing is because of a coarctation. And whenever any color flow comes towards an obstructed area, so this indicates a sometimes you may not see, but always try to look for a coarctation, some special group of cases. Always look, and when you see this here, you see here is the normal flow, and at the cort level, it is about a turbulence, and this is the flow across it also. So do not get biased by the referral diagnosis. Form your own clinical impression. Never be content with one diagnosis. Examine every structure and use multiple imaging planes with proper sequence. Liberal use of a Doppler and color flow mapping. Always explain why syndrome. Why syndrome means I showed you a case where there was a aorta dilated with LV enlargement. Why? We had a patient of pericardial RV enlargement. Why? So that gives you a thing. And that is why you must practice always all the views also. And don't worry, things might have looked very difficult today, but over a period of time when you do yourself, when hands-on session giving, things will be more clearer to you in the next talk or so. So the practice getting all scan planes and go stepwise, never be in a hurry. If you are in a hurry, you can never do it. Because the knowledge is a journey and not a destination. So you must do it what you want. Thank you.
Thank you, sir. We can ask questions. Anybody if has a question, please raise your hand so that I'll be able to call your name one by one.
I told them to go on interrupting, but they're very
Dr. Sachi Surendran. Okay.
Yeah.
Dr. Anil, go ahead.
Sir, how will we differentiate between subaortic stenosis and membrane seen in dissection of aorta?
Between the
Subaortic stenosis and membrane seen in subaortic
no subaortic
dissection of aorta. Dissection of aorta and
yeah
subaortic
subaortic
stenosis.
stenosis will only be will be seen in the subcostal view, but the dissection will be seen in the aorta. Now see here. So the dissection is as I showed you that the dissection is mainly seen in the aorta, which is dilated, and the subaortic membrane is seen in only the subaortic area, which is in the uh, beyond the just in the alveoli. So they are entirely different. Then its subaortic membrane uh, will usually be not that mobile, as you can see in a dissection flap, and I'll show you one which I did not want to show you. So that there are chances also. Then history is very important. In a history, you can hypertension hit. I said always take a clinical impression. Never go directly to the aorta. So you take a clinical impression, hypertension, unequal pulses, backache, and many other situations, and that will give you the hint. And the subaortic membrane is usually not that mobile, and it is mainly seen from the subaortic area and not from the aorta. So that is how you differentiate it. And the subaortic membrane gives you a significant LV hypertrophy. It gives you a signal. You see here. Now see, this is the transesophageal view. You can see the huge big membrane. This membrane is highly mobile, and it is causing a highly violent causing LV of obstruction. Now a subaortic membrane will be just below the aorta, and it will not be that mobile. Number two, it is one of the causes of a significant LV hypertrophy. Whenever we see a case of hypertrophic cardiomyopathy, we always look for a subaortic membrane. So there are definitely many ways to differentiate between the two.
Anybody else?
One more question. What will be the finding of MVP in M mode, sir?
Well, forget about the M mode nowadays. Say, I will show you, but normally we don't depend because M mode is a unidimensional structure. So we don't diagnose M mode by this. But unless you have really got this, otherwise you avoid doing a M mode only for unless it is gross prolapse also. When there was M mode only during our time, then we were mainly doing M mode. But now, if you have got the facility of a 2D, 3D echo, why go for an M mode? So because you see now, you see now here you see this is the anterior mitral leaflet. This
Yes.
is the posterior mitral leaflet. You see, there is a significant prolapse of the posterior mitral leaflet. And here you see, there is a significant prolapse of the posterior mitral leaflet. But sometimes you can miss it on an M mode. But you can see, if need, there is more of a academic interest. You, instead of putting at the tip, you put your M mode cursor on the PML and you can see a good posterior motion. But try to keep it more on a 2D, more of an academic interest also.
Okay, sir. Thank you, sir.
Anybody else would like to ask a question? Can raise your hand. Dr. Siripat Kore. Siripat, go ahead.
Sir, yes, sir. How to differentiate between physiological pericardial effusion and pathological pericardial effusion?
बताया था भाई, I just told you. say this is the, now see, this is a parasternal long axis view. Here you can see a little bit of a echo-free space in systole only. In diastole you don't see. This is because of the certain amount of pericardial fluid which is present. And as I told you, this is present only in systole, not in diastole. Now these are the two membranes of the pericardium. You see the separation only in systole and not in diastole. While in a true pericardial phase, you see both in systole and diastole. So this is how you calculate also that it is only seen in systole, not in diastole, and it is the separation is only in systole in those cases. So these are the physiological ones, and it not any much significant. You can say that it after it is the pericardial sphere, but more of a physiological.
Yes, sir. Thank you, sir.
Dr. Jahangir Jayawant.
Namaste. In apical view, uh, uh, we put the transducer where in subapical region, left atrium and right atrium, they are nearer to the transducer. Why it is so? LV and RV are away from it.
So what? Your transducer is here. These are more superior structures. So the nearest is LV and RV. I think. Have you been given a sort of a hands-on demonstration or not?
Yes.
So in a parasternal long, so it depends upon in a parasternal long axis view. You see the first structure there in RVN and LV. So they are anterior and the LA is posterior, or what you call it superior. So it depends upon the location of the structures also.
Okay, thank you.
No, don't worry about that.
Dr. Ali Qasim.
Good evening, sir. So can you hear me?
Yes, yes.
So sometimes pericardium, normal pericardium is very reflective. How can we differentiate from pericardial calcification from normally reflective pericardium?
Restrictive pericarditis.
No, sir. Pericardial calcification, sometimes normal pericardium is very reflective. Sometimes we find difficulties whether it is pericardium or normal pericardial calcification or normal pericardium. And then how we can differentiate from pericardial calcification from normal
Say
pericardium.
the normal thickness, poor diagnostic criteria for a pericardial thickening also. For example, the this is already a sort of a very echogenic structure. It is always a very echogenic structure. So you can see this, the most echogenic structure is always the pericardium. And when this pericardium thickening is something, if you're on an M mode, sometimes you can see a parallel echoes or so. So I think you leave it for the time being. Once these questions should ask when we give you the second talk. What are the signs of a thickened pericardium? Correct?
Sir,
So can I take this question? Very simple. Dr. Mohammed, look at the gains of your posterior pericardium and anterior pericardium. Majority of time our gains are very high in the posterior pericardium, then that looks to be little reflective number of times. So adjust your gain. Majority of us are using a harmonic imaging. Which machine are you using, Dr. Qasim?
Philips, sir, Affinity 70.
Affinity 70. How the TGCs are kept?
Hello.
How do you keep your TGCs?
Trans gain, sir.
Yeah, trans gain compensation. How do you keep that? Straight or little bit on right hand side?
Sir, curvilinear.
Yeah, correct. Go and make it straight. The pericardium will start becoming non-reflectant.
Thank you, sir.
Dr. Neeraj Dodke.
Good evening, sir. Sir, how to ascertain the left ventricular hypertrophy?
Say the criteria for an LV hypertrophy, I say normally the nowadays when you see the LV thickening, we normally say it's about 10 to 11 millimeters also when you measure from these view also. So sometimes, as I told you, when there is a very oblique imaging, I'll tell you, but I'll bring this slide just now. You can best is to measure from a 2D, from a 2D now see, from a 2D method you can get. If you are not able to measure from a 2D, then you go for the M mode also. But the normal is that when it is between 10 to 11 millimeters, and then it is there. But remember, we get many patients. Nowadays, we are in the era of a body surface area. So the many of the athletes and the patients with a large body surface area have got a increased thickness of maybe more than 12. Athletes can have a thickness of up to 30 millimeters. So you have to see. So these are physiological ones also. If your imaging is very oblique, you can get a thickening also. So remember, at the correct level, the thickening of about 10 to 11 millimeters in diastole is indicative of increased thickness.
The thickness of the posterior wall or anterior septum?
You measure both. Say when uh, when you measure both also, but IBS thickening usually 10 to 11 or so. Sometimes it will become very difficult to measure the posterior wall, but anything you have to measure both. Only then you can describe distance between the. Now you see here. This is the septum. This is the posterior wall.
Yes.
This is very much thickened, and this is less. So this is known
Yes.
as an asymmetrical septal hypertrophy. So if the
Yes.
ratio is more than 1.3 or 1.5 is to 1, it is the asymmetrical. So
Sir, at
you have
what
to,
level do we?
you normally at the level of the mitral wall.
Okay. Okay.
Normally at the level of the mitral wall, you see, uh, this patient was the case of a subaortic stenosis. You see, there is a membrane here, and see
Yes.
the massive hypertrophy, and this was misdiagnosed as a case of HOCM also. So at the level, usually at the level of the mitral, just beyond the level of the mitral wall where you measure the LV also. So we'll somehow other measure here also, and if you measure here, sometimes it is more also. So these are things also. And that is why we always measure the posterior. Now see, this is about 20, 21, and this is about 12. And so this
Yes.
is known as an asymmetrical. So always measure both to differentiate whether it is concentric or eccentric or what.
So if any of the wall is more than 15 mm, it is LVH.
Usually the criteria, they don't go by one single figure. The
Okay.
main definition of a hypertrophic cardiomyopathy is that any segment of LV more than 15 millimeters in absence of any condition of an increased afterload. That means hypertension, aortic stenosis, all this thing also. So, but sometimes we have seen patients of hypertension which have gotten a more than 15. We have got patients of a severe right-sided disease which can cause a कभी तो आप उसमें लगे रहो जो आपका नॉर्मल वेदर है.
Neeraj, presently you should think of anything more than 11 millimeter as abnormal.
Okay. So normal is less than 11. Yeah.
Normal is less than 11 millimeter. Anything more than 11 is considered abnormal.
Okay.
Dr.
Thank you.
Yogendra,
Sir,
this one,
Sir, 11 applies both to septum as well as posterior wall, sir.
all.
Yeah.
Okay, sir.
Yogendra, this one.
Sir, good evening. Sir, actually, it was how to differentiate between LVH and the HOCM, sir. But sir has told already in the previous question, sir.
All right.
So
Dr. Ripan,
is it only the sir, SAM we can add on to the criteria. If SAM is present, we can call it HOCM, sir.
SAM can be present even in other situations also. See, the thing is that you can see this is a hypertrophic of ductal cardiomyopathy line in front of you. In systole, you can see a wall going above also. Normally, the LVOT obstruction is because of a combination of LVOT thickening and the SAM. So that is SAM is one of the characteristic features of an hypertrophic obstructive cardiomyopathy and not the of HCM also. So you see, so SAM can be found, increased LVOT gradients can be found in the other situations. When we see increased LVOT gradient, that means more than 30 millimeters or so mercury. So these are the criteria. अभी तो आपको कितने दिन हुए कोर्स को? See, so this is the SAM. And you see there is a massive septal hypertrophy. Here you see SAM, a massive septal hypertrophy, and this is the posterior wall. Very less and less compared to this. So this is the pathogenesis of a SAM, and this is LVOT, as I told you, whether M mode or anything between the mitral valve and the septum with the LVOT. तो ये तो आपको भी तो वो step wise हाँ.
Wait for some more time, Dr. Yogendra. Dr. Ripan, can you go ahead?
Yes, sir. Good evening, sir. Sir, can you please show me the slide of aortic valve cups and explain it once again? Aortic valve cups.
So there are normally 3 cusps.
Yes, sir.
इस टाइम क्यों नहीं पूछा? See, normally this is systole. As I told you, in diastole sometimes the 3 cusps may appear that there. But if somebody asks you how to see the aortic cusp, say in short axis view, in the view of systole. Now this is the right coronary cusp, because the right coronary artery comes from about 11 o'clock position. This is the left coronary cusp, which comes because of this is the left main coronary artery. And this is the
non-coronary.
non-coronary cusp, which come from the with the left and non. You can see the 3 aortic cusps also. What I wanted to show you that you see here. In diastole, you can see there are 3. It appears there is the right, left, and the non, but the non will not be that large also at the near the septum. So that and here, which you move it also, you see it's an elliptical shape, 2 cusps. So if you have to go by clinical picture, there will be an aortic, there will be a stenosis or a regurgitation, there will be other findings. So you see it is there. So next time we'll bring you a movement of the normal 3 cusps. So you can see this, and here it is the 3 cusps you can see. So you always, now you see, here you can see one cusp like this. Sometimes there may be 3 cusps, but 2 or few. So there are many variants of this. As I've written that there are limitations and the variants of this also. But 3 you can do job regular echo करोगे तो 3 आपको दिखेगा आता.
Dr. Ravi Bala Mahajan.
Thank you, sir. Thank you.
Good evening, sir. So please explain normal motion of mitral valve leaflets.
तो ऐसे पूछ रही हो कि how many cusps have the mitral valve?
2.
Which
Mitral
are
valve
those?
bicuspid, sir. Anterior mitral valve leaflet and posterior.
अच्छा.
सर
And
वो एंटीरियर का तो समझ में आता है कि वो इंटरवेंट्रिकुलर सेप्टम तक जाता है, पोस्टीरियर का नहीं समझ में आया सर।
देखो, ये एंटीरियर है,
यस सर,
ये पोस्टीरियर है.
यस सर,
The anterior is in relation to the
पोस्टीरियर एओर्टिक रूट।
posterior aortic root.
यस
Now I
सर,
want to show you the M mode wala your mode. Yeah. Now see, this is the anterior, this is the anterior, this is
यस सर,
posterior. Correct?
यस सर,
This is diastole, end
यस
of the
सर,
T wave to the QRS complex.
कॉम्प्लेक्स।
The anterior mitral leaf movements anteriorly. The posterior leaf goes posteriorly,
ओके सर,
and they meet in systole as a single line. So
यस
this
सर,
will be shown to you when there is a lecture on mitral stenosis. So what happened?
ओके सर,
But remember this. We'll show you M-shaped or W-shaped later on also. But remember, this is diastole, this is anterior, this is posterior, and here at the point of QRS, they meet in one line or the systole, which is at the end of the T wave. So this is the same thing which carries on everywhere.
यस सर,
ठीक है?
यस सर, थैंक यू सर।
Dr. Lalit Bhardwaj.
Yes, sir. Role of color flow mapping in plex view, sir, where most of the blood is moving horizontally.
Let us come to an image. Now, say the role of color flow mapping is everywhere. Somewhere it is more, somewhere it is less. Say, for example, in a parasternal long excessive, suppose an aortic stenosis, we can see a turbulence beyond here. But we cannot take a Doppler there. In mitral stenosis, the blood goes from LA to LA, we can see a turbulence. But if you want to see many things, suppose it's a ventricular septal defect, the blood will go like this. So you will be completely parallel to the septum, like this. So you see in a parasternal long excessive, other things will show you a related turbulence and give you an idea that there may be this obstruction. But if you want to measure a gradient or a velocity, then you take this VST will be here. Then we'll did not show you today. Suppose there is a rupture of the sinus of Valsalva, it will go directly to all the transducers. You can take it there. So here, any lesion which is parallel to the interventricular septum can be used for a Doppler, but you can see the turbulence in cases of BST, aortic stenosis, mitral stenosis also. But calculations we don't do. Calculation can remember parallel.
Is that clear, Doctor?
Yes, sir. Thank you, sir. Thank you very much.
तो तुम लोग सो जाके.
Okay, all right. Anybody else?
अब तुम लोग पढ़ना then clarify करना.
Dr. Tanmay, go ahead, Fatah, quickly.
Sir, in the COPD patient, the parasternal view becomes getting parasternal view becomes difficult. So, in that situation, how to take the left ventricular measurement, sir?
ऐसा है कि देखो, in there is I just see many patients in which all use are bad. Now there are everything you cannot do perfectly. I agree. If your imaging is very poor, then you cannot take a measurement also. If you get a good short axis view, you can get some measurements. So you can try a short axis view at the mitral level or other levels also. But if that is also not available, then you can take a general idea from a subcostal or an apical view also. The measurement may be difficult. Okay, but for example, in COPD, the best view you can get is in a In a short, it's in a subcostal view. So you have to take everything. Many patients in many patients we write LV dimensions not taken because of very suboptimal imaging. However, do not appear to be increased. We don't be very dogmatic also. For example, you have seen a out of phase motion. You can say that paradoxical motion there, hence it could be variable. So these are some of the things also. Say sometimes suppose this posterior wall is very much atrophic, your LV size increases. Then we write LV is large, but part of it is contributed by atrophy and poor systolic thickening of this. So there are various ways also. तो आपको शुरुआत से तुम लोग की पता चल जाएगा ऐसे पढ़ते रहो इट इज गुड the more questions you ask the better it is.
All right, anybody else?
Right. I'm Dr. Shekhar. So how, please repeat the tetralogy fellow and VSD. Please show the picture how to differentiate the VSD from tetralogy of fellows. Mane overriding of aorta.
Very say in this way I got then I have to look for the lectures. I have to look for all lectures. But remember, there will be a talk on a congenital heart disease, okay, including fellows. So what happened there in a short? So what is this fellow tetralogy is characterized by an overriding of the aorta, VSD, RVH, and pulmonary stenosis, and anywhere also. It will be a low velocity flow. Say the VSD flow depends upon the difference of pressure between the LV and RV. So there are many things also. We'll just hold on. So we'll show you, tell you why there is a low velocity flow. Normally it is a high velocity flow. हमें पता है कि तुम लोग
we'll show you Dr. Shekhar sometime later on. Just give us some time.
Okay. Thank you.
Hello.
Neeraj, go ahead.
Hello. Hi, sir. Sir, you said that in today's clinical practice, we use mostly 2D echocardiography for most of the pathologies. So what is the clinical significance of using M mode in today's clinical practice? Where do we use it exclusively?
Say, ऐसा है कि M mode has not yet lost its value also. But sometimes if you have got a, let us start from the basic. Whenever you have got a sometimes a difficulty in measurements also, there's with some I've shown you, but the ideal is 2D, but if you cannot get it, then it's there. Many of the, for example, the SAM, it can be very well seen in an M mode rather than the 2D. 2D will only show you, but the measurements of this. Functions, we don't take it this. Sometimes you can, everything is there. You can measure a pericardial effusion by a 2D or even M mode also. So it has not lost its value also because of its rapid rate of the sequence of events also. So, but definitely many personal measure they use M mode, but not for any LV functions also. But you'll see as you proceed, we see M mode. Now, for example, in mitral stenosis, we don't use M mode that much. Its value is coming down, no doubt about it. But
like in LA by AO ratio, we use in 2D as well in M mode as well. So what is more accurate?
When there was only M mode echo, then the aorta LA ratio more than 1.2 to 1.3 was considered as an indirect evidence of LA enlargement. Now, if you see, we are going more for a LA volumes and other things. And LA enlargement can be very fallacious also. And LA can enlarge in various directions, not only anterior-posterior. A LV, LA, we are usually measuring in, let us say, parasternal long axis view. Or sometimes it can enlarge in a lateral view also. So So it is an indirect evidence also, but normally आजकल aortic this LAOA ratio is, now there are many situations in which the aorta may be small also, but LA is normal also. So, but 1.2, 1.3 was considered as an indirect evidence for this EO-LA ratio. So basic का भी है, but I think now you have got the value of seeing it by MO. You can see by 2D. You can measure area. Now we are going by more by area in the 4-chamber view, and any area more than 20 centimeters square indicates a LA enlargement. So there are a lot of things on LA or RA. So only giving a sort of a value that is a sort of a, for your level, I would suggest, I may be wrong, that give a dimensions plus an area. And we have got now and a body surface area also. As I told you, we get patients with a 45 millimeters LA, but they are huge big people. So that is why we are now in a stage of a body surface area. I have got a whole set of dimensions according to the body surface area. In the next talk, we'll let you know.
Okay, thank you, sir.
All right, friends. Thank you very much for your patience hearing. Thank you very much, sir, for your excellent talk on how not to
Okay,
miss lesion by conventional imaging.
I hope tomorrow you sort at quarter to 8 now.
Yes, sir. I've sent the link to everybody, and you're.
पौने 8 तक हम लोग तो कर लेंगे.
I'll join by quarter to 8.
Okay, so you
Okay,
are the
sir.
host. You are the host ना इसलिए. Okay.
I'll join definitely. So thank you very much, sir.
Thank you, sir.
Thank you.
Thank you, everybody.
Thank you, sir.
Thank you, sir.
Next week or tomorrow, sir?
Thank you, sir.
Thank you. Thank you, sir.
Thank you, sir.
Thank you, sir. Good night, sir.
Next week.
Thank you. Bye bye.
Sir, good night.
Thank you, sir.
Thank you, sir. Good night, sir.
Thank you.